Hello, everyone. Good afternoon. This is Dr. Khan, Executive Plastic Surgery. This is Bloomfield Hills, Michigan, and also Greater Los Angeles, California. A warm welcome to the many new members that we have joined over the last week and several weeks and months. And a warm welcome to any new members and non-members who are listening. This is a educational, informational session so that I can answer any questions you may have. As a board-certified plastic surgeon, my practice is exclusively devoted to removal of breast implants, that is saline implants, silicone implants, and residual capsules. And as a board-certified plastic surgeon, I'm very happy to state, knowing what I learned during my education and from my experiences, I knew very early on as a medical student that it was not proper or healthy or smart and wise to get implants. And I learned about breast implants physically as a medical student in training, as a surgical resident, as a plastic surgery fellow. And then upon my practice, I said I was not going to do something that ultimately my heart did not approve of. And as you can see, I put only one implant in my entire career in order to get board certified. And as a biochemist in my undergrad, in my training, and having learned the many different aspects and fundamentals of biochemistry and the molecular nature of implants, I kind of put the two and two together, and I understood what is a very easily comprehensible understanding of what are the harmful effects of getting breast implants. And this is where I objectively, not my opinion, talk about what is breast implant illness, what the manufacturers are saying, what the FDA is saying, what history is telling us, what ultimately the patients are saying. And this is where you will see this is something that is only getting more and more solidified. It is only common and normal and proper to see almost every plastic surgeon offering explants. And this is where you will see that the trends for explant is up, and for very good and obvious reasons. Now, the one thing I just want to start off by mentioning, I get this question asked a lot, why and how did you realize? And, if you look at the FDA warning, and I'm just going to go ahead and pick up this publication. This is from the FDA. And again, this goes to showing you this is not my opinion. These are the words of the FDA. I want each and every single listener to kind of pull this up, go to Google and type in breast implants, certain labeling recommendations to improve patient communication, guidance for industry and FDA staff. This was issued September 29, 2020. And as you will see, if you look at the black box warning, it says over here, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. And so the point here is ultimately the end result is only bad, which means that, and this is again consistent with the many patients that I have talked to, a patient that I talked to who just had implants in 2025 and her body started encapsulating and forming the capsular contracture. So in her case, she's having pain on the left side as a direct result of the implant, and that is an indication to intervene surgically. And what is interesting is this has happened to her previously from her first set of implants, and now it happened on the left side. And so this is where in just a short period of time that her implants were reactive. Just this morning, I talked to a patient who had implants from 1995, and she had signs, symptoms of breast implant illness, along with her symptoms of capsular contracture, and again, an indication to be removing them. Also of note, she had underlying ulcerative colitis, which is an autoimmune disease affecting the GI tract, which is ulcerations of the colon. And again, that in itself alone is a contraindication to getting implants. And the point here is that the implants are not health promoting devices. No one walks into my clinic and says my implants are making me healthier, I can think better, sharper, my joint pain is improved, I have more energy. If anything, it's the opposite. Remember, the effects are relatively only negative, and they do pile up for some people initially, soon thereafter. So a patient that I talked to a couple months ago, she had her surgery done in Korea, and just 2 months later her body went haywire, and she knew clearly it was a direct correlation between her and getting the implants and the reactivity. Her body was immediately reacting them. And so she basically knows in her heart and soul, a young lady in her 30s, that she needs to get these implants removed. And there are many patients, for example, who had implants in their 80s and who went through the Dow Corning time period where there was a class action lawsuit in 1992 where there was a ban on silicone implants, and she signed a waiver to basically keep her implants because she liked them so much and she was not negatively affected by them. But in the 2019 or so, she came to me and she wanted them out, and when I operated on her, she had what was a rupture of the left breast implant. So in her time, she probably had lived through, and her implant eventually ruptured. She had chronic pain and the inflammation from that in silicone, and she certainly at that time, so her time came a few decades later, but on average, plus minus 10 years. So if you look at the studies that have been done by the manufacturers at around the 10, 11-year mark, they stop doing these studies because the rate of rupture starts to go up. And the point I'm trying to make here is they're not lifetime devices, and there's only badness associated with them as time progresses. So again, just reading between the lines, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. So now this is needs to be kind of expanded on a little bit more. Now, the other thing I just want to mention here again is if you have any questions, please go to the comment section under TikTok, YouTube, Instagram, Facebook, and please certainly do ask the question and I'll be more than happy to answer. So if you look at this publication, again by the FDA, not my words, these are the words of the FDA, you will see, let's go ahead and look at the risks of getting breast implants, and I'm going to read them out so that you will know exactly what the literature says, what is the objective evidence. So it says over here at the second half of page 11, quote, and I'm going to read, I understand that there are risks of undergoing breast implant surgery. I understand the risks undergoing a breast implant surgery may include breast pain, skin or nipple areola sensitivity changes, asymmetry, impact of aging or weight change on size and shape of the breast, infection requiring possible removal of the implant, swelling, scarring, fluid collections, hematoma, tissue death of breast, skin or nipple, inability to breastfeed, complications of anesthesia, bleeding, chronic pain, damage to surrounding tissue such as muscle, nerves, blood vessels. And then the next page it says, let me go ahead and go to page 14 now. To the top, quote, I understand that silicone can migrate from my implant into nearby tissues. For example, chest wall, lymph node under the arm, and organs, liver, lungs, where it may not be possible to remove. So this is the gel bleed phenomenon, and I'm going to read the second part of the paragraph here. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. So if you think about it, this is huge. 1 out of 8 or 9 women will get breast cancer, and the implants will interfere with mammography or the self-monthly breast exam, and that will delay the diagnosis. This is not my words. These are the words of the FDA. That, if you ask me, alone in itself should and will be a reason to not get implants, if you ask me. Mammography can also cause the breast implants to rupture or leak, and I cannot tell you How many patients have I talked to who have stated exactly that they felt that once they got their mammogram that their implant, quote, started hurting them, or one patient even went as far as to see exactly what happened, that automatically she had an instant deflation of the right saline implant as a result of getting the mammogram. Remember, saline implants, if you ask me, should have been banned as well when the silicone implants were banned for cosmetic reasons, and certainly should have been banned for reconstructive reasons, because no matter what the reason, there's still the badness, right? So they should have been banned for all three reasons, meaning cosmetic patients and also reconstructive patients with breast cancer. And so saline implants cause the same hurt and harm as silicone implants, because the silicone shell of that saline implant is again leaching out, imparting particles of silica into the periphery. We have seen that in case reports that have been published by other physicians. We have seen that in lymph nodes that have been biopsied in patients that showed silica within the lymph nodes of patients with saline implants. And so this is where reports of silicone emboli from saline implants have been reported into peripheral tissues, which is what exactly the FDA paper is saying. I should tell the mammography technician if I have breast implants. Certainly, do no harm part. I understand that the long-term risks of breast implants may include painful or tightening of the scar tissue, which is the capsule, which is the capsular contracture, rupture or leaking of the implant, wrinkling of the implant, visibility of the implant edges, shifting of the implant, and need for reoperation. Now, the next line is very interesting. It says that I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of the silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. A list of these components are mentioned, and then they want you, patient initials, meaning the patients understand that the surgeons have understood this. Now, if you look at the next line, they talk about the screening for silicone breast implants, as far as getting an ultrasound and or MRIs. We'll talk about that later. And then, if you will, over here you see physician signature. I acknowledge that I have discussed the benefits and risks of breast implants as described elsewhere in the patient information booklet, brochure, and this checklist. I have also explained the benefits and risks of these alternatives. I have encouraged the patient to ask questions, and I have addressed all questions. Now, majority of my patients that I talk to, it is news to them that the implants are not lifetime devices, which is very interesting, because these patients should have gotten that informed consent. And unfortunately, even in today's world and age, implants are being sold as very safe, very effective, and the standard of care. And if you ask my professional opinion, certainly not that. Just today, I talked to a patient from Florida. And this is a nice lady, 65 years of age. She had her saline implants from the year 2000. So her implants are 26 years old. That in itself alone is a reason to be removing the saline implants. Plus, she has this underlying ulcerative colitis. That in itself alone is an independent reason to be removing the implants, the saline implants. And plus, she had the symptoms of breast implant illness that she mentioned. And she is, I use the word only 65, and she realizes, listening to the many other patients, that these are her problems and she wants these out. And now what's interesting is, this was my conversation with her. This was the phone consultation I did. And I told her, what's interesting is, if she went to the top 100 hospitals in the country and she were to get a professional opinion from the many plastic surgeons, almost all of them, if not all, would say replace these bad saline implants with silicone implants. And lo and behold, this is exactly what she said. Her local plastic surgeon had said to her that you need to get these bad old saline implants and get the newer version, which is the silicone. Now, what is unfortunate is, when she's going to be 75, she's going to run into this problem of potential rupture, replacement, and whatnot else. And I'll tell you, when you're that age, you do not want to be going or undergoing another surgery, because the more surgeries you have, the higher the risk for clot, DVT, heart issues, amongst others, right? Unnecessarily. Now, what is interesting is, if she were to go to 10 different explant surgeons within Florida, she knows that she is going to get 10 very different answers, 10 different surgical approaches. There is, remember, no textbook answer. If you look at the standard says leave the capsule behind, just remove the implant alone, and just pull it out from a small incision under local. And I will tell you, in my practice, that is a big no-no. In my practice, the whole surgery is about the capsule and that inflamed tissue. So she had her implants below the pectoralis major, and in my practice, I removed the entire implant plus that entire capsular tissue, preferably in what is the en bloc method, which is all as one system, or 100% total capsulectomy, and any other inflamed tissue around that. Now, in a normal patient, under the pectoralis major, you really have no tissue other than pec minor and then the ribs and the intercostal muscle. And so in my practice, I remove not only the implant, which anyone can do, by the way, but the whole capsular tissue in its entirety. Like I said, preferably in en bloc fashion or 100% total capsulectomy, and any and all inflamed tissue in the periphery, such that only good, healthy, viable tissue remains behind, and that all bad tissue is removed. And so the breast tissue is not touched. And I'll say this again, the breast tissue is not touched, because there is this only the horizontal incision that goes right into the crease, and it basically hides in the crease. And this is where I remove some of the excess skin, which is that Kahn-Decay pseudolift, where I remove the excess skin and I tuck the breast tissue medially towards the midline and upward, such that the patient ends up getting this pseudolift without touching the breast tissue. Remember, no one should cut in and around the nipple areola up and down, because that will lead to insensate scars, hypertrophic keloid type of scars, white scars, hypopigmented white scars, loss of sensation around the nipple areola in some select patients, inability to breastfeed in some select small patients. And sometimes when you do a self-monthly breast exam, the patients find these irregularities, nodularities in and around the incision, and now they're thrown off if this is a breast mass that is possibly fat necrosis, suture material, benign tumor, or breast cancer, and now the patients are getting these unnecessary biopsies. So the point here is, if you go to 10 different plastic surgeons, without a doubt, you're going to get 10 different surgical approaches. Many surgeons say, if the capsule looks good, leave it behind. Absolutely not in my practice. In my practice, I remove the whole capsule. And this is where I say to every single patient and surgeon who's listening, that you have one shot at it, and you have one chance at removing the whole thing in its completeness. So 3 weeks ago, I was in California, which is where I go to operate every 6 to 8 weeks, depending on the schedule here in Michigan. I remove a saline implant that had fluid around that saline implant, and it was all contained in the en bloc. And this is where none of that fluid spilled into the chest, and this is where en bloc was the standard. And the patient did not need drains. The patient did not need a washout. And it was done in a very thoughtful, systematic, calculated way, no matter what and how long the time took. And it was done systematically, only from a horizontal incision, no up and down cuts. The patient has the videos and the high definition pictures of the chest wall itself, showing complete removal of the entire implant capsule, and the patient is content that everything bad was removed, and everything bad that was removed was indeed very much tested. And this is that very direct, transparent care that you will see that I provide when you get operated by me. Now, I'm very happy to announce, and this is what I would say is a major announcement, that with the help of Dion, we have, who's my IT social media manager, we have a brand new website, which is Dr. Khan gallery.com. Dr. Khan, that is KHAN gallery.com. And here we are going to put thousands of pictures and videos of me cutting open the entire implant capsule, intraoperative pictures of the chest wall showing complete removal of the entire implant capsule, which is, if you ask me, the most important video to see. And then also we're going to post the before and afters, which many people have been strongly considering. Now let's go ahead and expand on this. This is where we're also going to do the many lives from the operating room directly, so you can see exactly what happens when the implants are removed and cutting open of the implant and capsule. That will be telecast live on the webpage. And then also you will be able to basically connect via Facebook, Instagram, TikTok, and YouTube directly onto this webpage, drkhangallery.com, and you will be able to join us directly. In the past 6 months to a year, we have had difficulty with Facebook and Instagram because these were too graphic for them, and AI was basically disregarding us. Now we have the medium where we're going to be able to connect directly to you from the comfort of your own home or office or your own space, and you will be able to merge live directly into the operating room, and you will be able to see exactly what is happening and how the patients are benefiting, and the complete transparency. Again, the most important video, and this is what I ask each and every single patient to ask, and I voluntarily give it before the patient even asks, is the high definition pictures and videos of the chest wall showing complete removal of the entire implant capsule and that fascia of the respective muscles. So that means the capsule adheres super tightly to the fascia of the muscle, which means if the implant is below the pectoralis major, the implant is sitting directly along with the capsule on top of the rib. So in my practice, I remove the implant plus the capsule plus the fascia of the intercostal muscle. Intercostal means in between the rib, that is the muscle, the fascia of which I remove, the periosteum, perichondrium, the fascia of the pectoralis minor, and the fascia of the serratus anterior, because that is what truly ensures a complete end block. I cannot separate the capsule from the fascia. So either the capsule has to give or the fascia has to give. And the only way to doing a proper end block or 100% total capsulectomy is where the fascia has to be removed. And it's very safe to remove the fascia and the periosteum and the perichondrium. Anyone who has had a femur reconstruction or a plate on their bones or any reconstruction of any bone, they denude, remove the periosteum. That's where they put the plate directly on top, or the screw. And so it is very much acceptable. We harvest ribs on patients to reconstruct the nose and using the ribs as a spare part. So if that can be done, removing the fascia of the periosteum, perichondrium is certainly absolutely very safe. And if you ask me, the only one way where the capsular tissue can be removed definitively and correctly and with definitive transparency and certainty. So one of the surgeons from France asked, okay, I don't think you can do it all the time. And I said to that surgeon, if you look at my patients and ask each one of them who has those high definition pictures and videos, you will see the raw muscle of the intercostal muscle, the periosteum, perichondrium denuded of the rib denuded of the periosteum and the perichondrium, the fascia of the pectoralis minor, and the fascia of the serratus anterior. Now remember, this is the only one proof. If I see a high definition picture and video of that chest wall, I can say with certainty that it was done correctly. And not only down here, but all the way up here. I've talked to many plastic surgeons who say it is relatively hard, and you bet it is definitely an involved surgery. And this is a surgery that's discouraged. No, it is the only way, if you ask me. So if someone has CD30 positive or a sign symptoms of of that BIALCL, which is breast implant associated anaplastic large cell lymphoma, the surgeon is obligated, required to remove the whole capsule, period, no questions asked. So in my practice, I go into each and every single case thinking the patient has fungal infection, patient has BIALCL, patient has BIASCC, which is very rare of rare of rare. It's like getting struck by lightning times two. But still, we know it is underreported, and it has to be done in order to basically do it correctly. So those three patients in the last couple of years who had CD30 positive, my own patients, I did not have to go back into their chest in order to remove or redo the surgery correctly the second time around, because they got the surgery done correctly the first time around. Now, the I go into the surgery thinking that patient has positive fungus, positive BIALCL, which is the breast implant associated anaplastic large cell lymphoma, BIASCC, which is breast implant associated squamous cell cancer. The patient has breast cancer or any basically potential silicone that is ruptured. Even if the many patients that state they have saline implants, I always assume they have silicone that's ruptured or they have fluid around the implant, because remember, we want to contain all of it. And the one ultimate proof that the surgery was done correctly is the high definition pictures and videos. One patient of mine actually came to me and said, "Are you sure you got the whole capsule out?" And I said to her, "Please come get me those pictures and videos that I showed you, and have your husband come in, because two minds are better than one." And then I asked her, "Let's go ahead and look at those high definition pictures and videos." And she and I and her husband looked at them, and I said, "Look at this raw muscle. Look at this raw rib. Look at this raw serratus anterior without the fascia. Look at all the way up into the upper chest. This is direct proof, 100% certainty that everything was removed." And she said, "I'm happy." And when I asked her what gave her that thought, she said she sought another plastic surgeon who questioned. And when I said to her, it is impossible because this other surgeon is not inside the OR. Did that other surgeon see the high definition pictures and videos? He himself possibly is not able to do it, with all due respect to him. But the bottom line is those high definition pictures and videos prove everything you need to know, because that is the ultimate proof. Unfortunately, I have seen many patients who have had supposed total end blocks, and when they had their surgery done, they did not meet that 6 criteria in my mind that kind of show you and convince you with absolute certainty that the surgery was done correctly. Number one, their incision was so small and their implants were relatively so wide and big. It is impossible to remove the implant from a small incision definitively, correctly, completely. So the diameter of the implant dictates the length of the incision, and that is absolutely the right way, because not only are you going to be able to dissect here, but you have to go all the way up here, and from a small incision you cannot dissect all the way safely. Number two, the length of time. There was another patient I talked to over the weekend. She had surgery done over 2.5 hours. I will tell you, it is impossible to remove a 550cc implant in 2.5 hours. And this patient, unfortunately, had not only a supposed explant, but a lift and fat grafting done in the 2.5 hours. If you ask me, if you call a surgeon up and you have no implants and you ask a surgeon, "I want a fat grafting and I want a lift," they will quote you 3 hours. So how is it humanly possible to do a explant in the same time? And so that was a big red flag. Number three, the high definition pictures and videos were never done, and that in itself speaks volumes that the surgery was not done correctly. Number four, the capsules were not sent to pathology. So this one patient, I saw her supposed total capsulectomy and I saw her pathology specimen, and it was only 2 by 3 centimeters. That in itself told me automatically she did not get the entire capsule removed, and it was cauterized and left behind, and that is consistent with incomplete removal of the capsule. So the capsules, when they're sent to pathology, the pathologist, the first thing they do is they measure using the ruler the dimensions of that exact capsule. So if you have a capsule that was 15 centimeters by 12 and a half by 3, and the implant was 550, I say that is consistent with the total capsule removal. And that is in itself proof. I have a surgeon acquaintance that I met at a conference, and he said because he cannot remove the whole capsule, he does not send it, or he removes part of the capsule and sends bits and pieces of it that he finds interestingly problematic. Remember, the surgeon's eyes cannot tell if this is cancer or no cancer. The only thing that can tell is the pathologist staining it with CD30 and doing the appropriate workup with ruling out breast cancer, BISCC, and looking at it under the microscope. The surgeon has to send the whole capsule. So that's the fourth thing, the capsule must be sent. Number 5, the surgeon is not placing drains. If you ask me, if a surgeon's using drains, in my eyes, in my professional opinion, that automatically means there is badness left behind that warrants or necessitates, mandates placement of drains. So I did a Facebook Live with a nice surgeon from the Netherlands, and she said she tries to and does her best to get the capsule out on the lower part of the chest. And on the upper part of the chest, which is indeed the hardest part of the case, the surgeon just cauterizes. She cauterizes the capsule and washes it out, irrigates it with some saline, and puts drains in to kind of help clear out the inflamed debris or the burnt out capsule. And that is a big no-no in my practice. I physically remove the capsule plus the implant plus the fascia of the serratus anterior, pectoralis minor, periosteum, perichondrium, intercostal muscle, and that in itself guarantees removal of the whole capsule. And number 6, last but not least, the transparency of the surgeon on social media. I had a patient that went to another surgeon who refused on social media to mention that breast implant illness even exists. That in itself is a red flag. And your surgeon must be openly talking about breast implant illness. So they have it on their website, but they're timid about talking about it because truly their heart's not in it. So many surgeons that I've talked to at a conference or basically on social media, they do not want to acknowledge breast implant illness truly exists because they will scare away their other many patients who are getting augmentations. And remember, this is a surgery that is all about transparency, about firm belief, sincerity, professionalism, and integrity, where your surgeon must be solely devoted into removing the implants, should not be doing any augmentations at all, because that nullifies his or her belief into the proper technique. Now, the other thing I must mention is a year and a half ago, I got approached by a plastic surgeon who wanted to buy my practice and who told me I was not doing good enough of a job marketing myself and that I was not making good use of my quote-unquote space. And I asked him what was his point and how does he plan on kind of improving it. And this was something that he himself pushed upon me, hoping to be smart and trying to, capitalize on my quote-unquote lack of marketability that I do, meaning he said that I could be a lot more marketable and more busy. Now, I told him my practice is not about making money. Unfortunately, his practice, if you look at, is all about BBL. His practice is all about augmentation, and then he himself markets himself solely as a breast implant illness advocate, and he himself only explants, and now he himself is able to market himself better. And this is extremely unfortunate and unprofessional, where he said, well, I'm offering a service through my other colleagues who are part of the same team, and they're able to capture those patients which I'm not able to capture. And between the 2 of them and 4 of them, they're able to market themselves effectively so that they're now able to cater to everyone. Patients who are augmenting, they get diverted to this other surgeon. Patient who wants explant, they get basically highlighted to him and his partner. And the point here is they're now selling themselves as explant only surgeons, which is absolutely wrong because they're still financially capitalizing on those augmentations. And this is where you have to do your homework and screen your surgeon, because every surgeon is different. And remember, that list of surgeons that's going around that's made by Facebook group owners or other top 10 surgeons in the US. Are all bogus, wrong, unprofessional, bad lists. There is no American Board of Explant Surgeons or this one person who governs and looks at capsules, pictures, and dictates, well, this is good. Okay, you go on the list because I like your capsules. No, it is all, unfortunately, a money driven, money hungry practice. And you have to, as a patient, be very careful about who you sign up with. You yourself have to, as a patient, talk to the surgeon directly. Do not talk to the PA, the nurse practitioner, medical assistant, or the front desk person. They are not going to be operating on you. You have to talk to the surgeon, and on that consent form, it has to be very clearly laid out. 100% total capsulectomy, preferably an en bloc or total capsulectomy, that in that consent form, you're going to get the high definition pictures and videos of the chest wall. You yourself are going to get the capsule center pathology. Cultures will be done for fungus, and you will have that complete post-op direct care by your surgeon, not by the PA. Unfortunately, many patients never see their surgeon ever again. This is where you yourself, the only one who knows what happened in the surgery is the surgeon and not anyone else, not even the PA. Remember, the PA is not a surgeon. And so the bottom line is you have to have that accord, that bond, that faithfulness, that sincerity, that transparency, that tranquility in your surgeon. And your surgeon should not be augmenting at all, or his entire practice should not be augmenting at all. And if you ask me, anyone who does BBL falls out of that list of surgeons. And if you ask me, the transparency has to be there with those high definition pictures and videos. Now, when you go to my web with the page, drkhangallery.com, that is DRKHAN gallery.com, you will see the high definition pictures and videos of the chest wall showing complete removal from one patient to the next. Unfortunately, many surgeons do the easy cases above the muscle, and now they have this big case that they use to advertise and claim to be very good surgeons. No, it has to be done consistently. So if you ask me, and I propose this to all my colleagues, and there is no HIPAA violation in any of this, every surgeon should have an intraoperative chest video showing complete removal of the entire implant capsule, because that's the only one and the only one way. Now, the other thing I want to mention here is this. One patient asked me in clinic yesterday, I want to see the before and afters. Now, I will say this to you. If you go to any surgeon's website of Explant, you will see the top 10 best Photoshop, possibly not even their own patients' pictures, model pictures, and you will be mentally, psychologically pushed into thinking that this is going to be picture number 11 is going to be me. Remember, there are so many variations from one patient to the next that you have to ask yourself, what is the age of the patient? What is the ethnicity of the patient? What is the size of the implant? So a patient who has a 800cc implant is very different from someone who had a 200cc implant. Someone who has had 4 previous augmentations is very different from someone who had it done once. Someone who had a board-certified plastic surgeon who did the initial augmentation, and someone who had a non-board-certified plastic surgeon. Just down the street, less than a mile away, we have an ENT surgeon, believe it or not, who's putting in implants nonstop. And he's done probably, God knows, well over 2,500 of these implants. And he is ENT, ear, nose, throat. But this is, unfortunately, the system allows for him, general surgeon a few miles away, doing implants. And he's done probably, God knows, over 5,000 of these in his career. Another ER doctor, not too far from here, where we are in Michigan, and certainly in California and all these places, implants being placed by non-board certified plastic surgeons. So you have to be very careful. So a surgery is done by a non-board certified plastic surgeon through a belly button, or through the nipple areola incision or the inframammary crease incision, is going to be very different result than someone who has done it correctly as a board-certified plastic surgeon. Someone who has had a radiated chest after lumpectomy and radiation and an implant is very different compared to someone who has not had any radiation. One side may be different from the other because one side had capsular contracture and the other one was not did not have the capsular contracture. One was ruptured, the other one was not. One was malpositioned. So I have a patient who has had two reconstructions on the right, one on the left, and she had severe usage of ethibond suture in order to hold the implant. Another patient that I took care of in California, 78-year-old patient with 680 cc implant on the right with extensive use of alloderm cadaveric skin for a cosmetic case with extensive use of ethibond suture. Her results are going to be very different because of her age, ethibond usage, alloderm, which is cadaveric skin usage, her third implant that she had. And if you ask me, a surgeon who truly did not care about what was going to happen next, if her implant was going to rupture, and a very bad result with severe capsular contracture and extremely thin flaps. And it just hurt me for me to see her in that situation. And this was one of the patients I operated on when I was in Los Angeles, California. Now, the bottom line here is you cannot look at a picture and say, oh, I'm going to be like that picture. So when I made my website manufacturer, which is, a top 5 website, they said they take care of a lot of plastic surgeons and they have millions of stock photos and they would be more than happy to put those. And I said, absolutely not. So you have to be very careful. If you go to a website and you like those surgeons before after pictures and you're going to be like, hey, I'm going to choose that surgeon because of that, that is wrong and very unprofessional. And you have to understand that this is something that is significant and should not play a role. And patients do not necessarily realize this. Now, the other thing I want to mention here is, after this, I will take some questions. I have a patient who I operated on a few years ago who had her surgery done in Dubai. She's an international patient. And if you ask me, her surgeon, non-American board certified, did her surgery what is textured implants above the muscle. Any implant above the muscle is bad. Any good, reputable, board-certified plastic surgeon will place the implant below the muscle. Let me say this again. Any good, reputable, board-certified plastic surgeon will not be doing augmentations at all. And if they were, they would only place the implant below the muscle because that's less contracture, less problems, less inflammation, less badness. And she had her reconstruction done by what I would say a mediocre, bad surgeon, international in Dubai, if you ask me, above. And she had many irregularities, severe, significant inflammation, and her breast implant illness symptoms were through the roof. Now, she came to me in a lot of distress, and we were able to get her the visa, and I was able to operate on her in I used the word pristine way. And the entire implant capsule was removed. Total capsulectomy was done. Her breast implant illness symptoms pretty much disappeared. And she attested to the fact that implants clearly were causing her the harm and hurt. And the textured implants were the underlying total carpet, no design, no problems. Now, post-op, she ended up having, quote, this bad fold. And I did attribute that directly to that bad surgeon who unfortunately caused and made a lot of problems for me. Just like this 78-year-old patient in California that I operated on certainly made life, quote, hell for me when I was operating because of the extensive use of alloderm, ethibond suture, and she had no muscle on the right side. What is very interesting, and pec major muscle on the left, she had no muscle on the right side. And the patient was very much distraught when she saw no muscle. And I said, there was no muscle there to begin with, so it is not an issue. And she had those, again, high definition pictures and videos clearly showing what I found as I went inside. And this was her third surgery. So this is where, if you look at the bottom of page 15, I understand that breast augmentation may result in permanent changes to my breast tissue. And if my implants are ever removed, I may be left with unsatisfactory appearance, changes to the size and shape of my breast, including but not limited to dimpling, chest wall concavity, puckering, sagging, or different incision size or location. If I am an augmentation patient, any additional surgeries or medical procedures will likely be at my own expense. Close quotes. Now, this is significant. So a patient got fat grafting and she comes to me. I have chronic pain as a result of that fat nodule depositing right next to that nerve and causing pain. And I remove the implant capsule below the muscle. I'm not going to go seek out that fat nodule that has died right in the proximity of the breast nipple areola and causing her pain. She needs to go see the pain specialist. She needs to get that identified, that lobule of fat, and she needs to get that addressed. My role as an explant surgeon is to remove the entirety of the badness in a pristine way. And if I were to go back and that patient from Dubai or that patient from California, I am so fortunate and lucky and very, I use the word determined that I would not have done it any better. And if I were to go back and all my patients that I've operated on, the 300, 500,000, that I would not have done it any better. And you have those high definition pictures and videos. Remember, this is what most of my friends are saying to me directly behind the scenes. It is a huge liability for you to share your pictures and videos for what is a very controversial surgery, for a surgery that has a lot of potential issues and problems. And I said to them, each one of them independently, and I said, I am happy and I voluntarily shared this because I want to show to the patients that I got it all out, that the entire capsule implant plus fascia is removed, that only good, healthy, viable tissue remains behind, and all what was bad was sent to pathology. Cultures were done for bacteria and fungus. I did what is the twilight deep sedation. The patients have basically no unnecessary lifts, no unnecessary drains, and this is what I summarize as the Khan procedure. And you can go to ChatGPT or Claude, and you can certainly Google this, the Khan procedure, and you will see exactly what are the benefits of the Khan pseudo lift. Again, do no harm, do it completely, do it thoroughly. Another plastic surgeon, prominent head, reached out to me and I said, what am I doing? And I said, please talk to my patients. Go to my Facebook page, the largest gathering or following of any Facebook, of any surgeon, and you will see what my patients are talking about. It is a honest, sincere practice that's built on patients' care, number one, complete transparency. If anything, from a financial perspective, I lose money, quote unquote, by doing explants, to be quite frank. If you look at this surgeon who is doing an augmentation in half an hour, 45 minutes, in and out of the room, 45 minutes, and this is what we know of consistently. I did a Facebook Live with a nice surgeon who did 10 minutes each side. That's how fast he got. And you can listen to him, and he's now retired, but he looks back at his surgical experiences and he regrets doing the augmentations, and these are his own words. And he realized that he did a lot of harm. And the point I'm trying to make here is, this one surgeon told me when I went to California and all the surgeries that I did, he said he does all of those in one day and he's done by 2 o'clock. And the point here is, this surgery is, explant surgery is all about honesty, integrity, hard work, sincerity. It's not about making money. Number two, the big two things that hurt, in the same time that I do an explant, another surgeon has easily done 4 augmentations. So financially, my paycheck is cut by 3 or 4 definitely, no questions asked. Number two, believe it or not, it is a very tedious, meticulous surgery because it takes a toll on your neck and back and shoulders as you operate in that very meticulous, defined way. And the point I'm trying to make is, I talked to a couple of my other very close surgical friends who I've known for a long time, few decades, and they said they will never do that surgery ever because they don't want to hurt their neck and back, period. And they would rather do an augmentation and make a whole lot more. And when I asked them, and they're nice people, they said they're just offering a service. And I will say this to you, don't offer a bad service. And that's what I told them, because remember, ultimately the end result is only bad. Now I'll go ahead and answer the question, Dion, please.
Okay, so one lady, she has a 2-part question. So she was wondering, how would her breast look after the surgery, because she is afraid of being saggy and flat.
Okay, very good question. Let me go ahead and answer that. Now, very likely, statistically, her implants are below the muscle. So number one, I am not going to touch the breast tissue, the nipple areola, and I am not going to cut up and down around the nipple areola. I'm not going to make the lollipop incision, and I am not going to touch the breast tissue at all. And I'm only going to make the horizontal incision such that I'm going to be always operating below the muscle. So below the muscle is where I am. So the breast tissue essentially is not touched at all. Number one. Number two, I'm going to remove that excess skin at the bottom of the breast, not touching the breast tissue, just the excess skin. Because remember, the implants have only moved downward and outward in majority of the cases. And so that excess skin is removed, which is that con pseudo lift, con Dakai pseudo lift. And I tighten the breast tissue, kind of do like a tummy tuck out of the right breast and a tummy tuck out of the left breast. And I move the breast tissue medially and upward. And you're going to see these pictures and videos on that drkhangallery.com. So please be waiting for that. And this is the excess skin that I remove, number one. And I move the breast tissue medially and upward. Number two, because of the implant that's gravitating, pulling the breast tissue down, with the implant gone, the breast tissue in itself recoils because there's nothing that is pulling, gravitating the breast tissue down. Number three, sometimes there is a concavity of the rib that inevitably occurs as a result of the implant, especially when there is capsular contracture or a patient with a low BMI. With the implant gone, that concavity of the rib is no more because there is no pressure on the rib, and over the next 6 months, a year, the rib normalizes and folds outward, which is how the normal rib cage is, and not indented inward. And now that in itself will help. Number four, you will see from the many pathology reports and the many reports that the muscle is not truly used by those patients who have implants below the muscle, because every time you use your pec, you will compress the implant. It's a very awkward feeling, and the implant bounces up and down, just like a male bodybuilder's pec major bounces up and down. Your implants would bounce up and down, and you would have that animation deformity. So I require my patients to build the pec major and the pec minor, and that certainly adds 10-15% muscle mass to the chest and adds volume to the chest. Number five, what happens is anytime you have an implant in the proximity of the breast tissue atrophies, decreases, diminishes. With the implant gone, the breast tissue now can expand out, even if it is above the muscle, and now it fluffs out. So over the next year and a half, you will see that the breast tissue fluffs out. Many patients also notice that when they got implants in their 30s, 20s, even 40s, and now when they're 50, 60, they are a little bit on the heavier side, especially most post-menopause, or compared to when they got them. A vast majority of the patients, when they got implants, were much thinner, more slim, less BMI. And as they had kids and they put on weight, when the implant is removed, yes, they had the limited breast tissue, but they have fatty tissue that quote overrides that loss of volume, and that in itself basically adds volume to the chest breast area. And number seven, if you will, the skin. If I remove 10 centimeter of skin from a patient, let's say from the thigh or from the chest, and I remove it full thickness and I put it on the table to, let's say, do a face transfer of that skin at face, take that skin and harvest it full thickness, you will see that 10 centimeter length of skin that I harvest from the thigh will, when I put it on the table and put it back on the face, is only 6 centimeters. So it shrinks by almost 30-40%. Now, younger the patient, the higher the level of shrinkage, 30%, 40%. So if someone is 78, this patient has no elasticity of the skin pretty much. This patient has thinned out skin, and the qualities of the skin are certainly very different than when she was 38. So the younger patients, for example, have more of a recoil, more elasticity, and you will see that in itself allows for recoil of the skin. Number 8, you will see if you have inflamed tissue that's beat up, angry, irritated, inflamed, which is true whenever you have any implant, that tissue tends to sag more, is inflamed, gets stretched out easily. Very similar, analogous to someone who has a bad mosquito bite on the forehead. You will see when they wake up the next day, their eyes swollen shut, it's swollen. And so that swelling, you will see is present, that's the inflammation, the chronic inflammation that you see on the pathology report. With that inflammation gone, the skin recoiled even better and more, and is basically regained some of its elastic recoil capability. And believe it or not, in some patients, some nerves do come back because they were not stretched out, depending on how and what the surgical technique was. So if you look at all of these 8 factors, majority of my patients do not need that unnecessary, brutal, very invasive lift. I want you, number one, you don't need it. Number one, don't do a surgery that on a day where just the explant alone will take 4 hours. Don't do a surgery that you won't even need. Don't do a surgery that if you do need, you might run into complications. So I took care of a patient that had 1100 cc implant, 1200 cc implant from Arizona. She definitely 100% needed a lift. She'd been out to 5 other surgeons, and all of them had said, and including myself, yes, she will need a lift because her skin has been stretched out so thin, so bad that absolutely the skin is going to sag, and she will absolutely need a lift. But now is not the time, at the time of explant, to doing a lift. You have to do it at the correct time, which is a year later, and you have to stage out these operations. So you will see on social media where a surgeon was very new, rookie, and naive, and now the Mexico effect occurs, which means the surgeon said, oh, I will do an explant, I will do fat grafting, and I'll do a lift. And now the next thing you know, the fat necrosis occur, painful scars, painful lumps, skin necrosis, wound dehiscence, asymmetry, in unequal fat uptake. And now the patient is very distraught because a lot of surgery was done and care and attention was not done to the explant itself. And again, in my eyes, as a surgeon who loves to operate, I wish I was operating right now and not doing this live, if you ask me, to be quite honest. I would love to do a lift on everyone, but as you will see, most of the patients do not need the unnecessary lift. And I say this with complete sincerity. Look, I'd love to operate. I would love to operate and do more surgery and make more money. No, it's not required. So as a well-wisher, as a faithful surgeon, I'm telling you, most of the patients do not need. So I have a patient that I operated on, 74 years of age. She came from Massachusetts. She had a very good surgeon who did her surgery in the early 2000s, and she was sitting on the fence if she would choose the many other surgeons in the Northeast versus come to me, and she had good insight, and lo and behold, she had ruptured breast implants. And when I got done with the pseudo lift and all of this, just a few months later, and you'll see her video and pictures, she looks aesthetically amazing, if you ask me. And she herself is extremely happy, and she knew what she signed up for, and no unnecessary cuts in and around the nipple areola. Go to Google Images and type in intraoperative, intra means within operative, video mastopexy. Mastopexy, mast means breast tissue, pexy means the lift. And you will see those very invasive, very involved, the breast tissue filleted open lifts where, number one, they're not required, but you will see the breast tissues, if you ask me, never the same again with those types of lifts, because that's a lollipop anchor incision. And at a time for an explant, number one, you don't need the surgery. You're already putting yourself to a lot of potential risk if, God forbid, your implant is ruptured, or there's skin necrosis, because remember, majority of the times this is bad, inflamed, angry tissue, and you do not want to be manipulating and doing unnecessary surgery, especially when the focus should be on the proper explant. So if you look at this and you put the two and two together and you listen to your gut, many patients that I've talked to, if not all, are so happy they did not get that unnecessary lift.
So the same person asked, she's had her implants for 25 years and she needs them removed, and she wanted to know, why are you against the fat transfer?
So fat transfer, now don't listen to me. Go and listen and ask. I'm not a big proponent of going to Google or ChatGPT and asking them, but that's like a nice start, if you will. When you do, and this is my official answer to you, I'm not asking you to go to ChatGPT, but to help supplement, to understand, and help for clarification as to what I'm going to say. If you go to fat transfer, in my practice, it is absolute bad medicine. A big no. When you harvest the fat, the job is to basically spread the fat out, fan it out, such that that fat in itself deposits diffusely, so that each one of those fat deposits gets its blood supply, just like you would do on the face. And now that ultimately adds volume. Now, if you look at fat transfer, even if someone says, I'm the king of fat transfer, that means quote unquote garbage. That's like, you cannot say that, because fat transfer, fat augmentation to the breast tissue is inherent quality is where, if you look at the literature, anywhere from 30 to 70% of the fat inevitably will not take. There are parts of it where it will take, parts of it will not take. A good part of the fat gets liquefied, absorbed, and the body in itself processes it and absorbs it, depending on this patient's BMI, previous surgeries, radiation, the surgeon's technique. This is where a good part of the fat, 30-40% also, will inevitably get absorbed. Some of the fat will form and take, which is what we want, which is excellent, which is what the desire. Now, it will form, and sometimes it may show up as potential irregularities on a self-monthly breast exam. A small percentage will form oil cysts, oil emulsions, fat necrosis, small percentage. And if you go to the literature and look at, fat necrosis and how it's picked up on mammogram and ultrasounds and MRIs, you will see the breast tissue is never the same again, especially when that fat deposits next to a nerve. Now your self-monthly breast exam is altered and your mammogram is altered. A small subset. And now you are getting unnecessary biopsies, or there is unnecessary anxiety because they say, get a mammogram in 3 months to 6 months to see if this is going to grow. I have had many patients who have come to me where other very world-renowned plastic surgeons have done fat transfer, and now the fat is sitting right next to the implant, and now they're concerned about wanting to biopsy, but they're afraid to biopsy. And now the patient wants to get an explant and is more concerned about this mass than the explant, but wants to do the explant correctly. And now the task is to remove the implant capsule and remove that mass as well, which is that suspicion. Remember, 1 out of 8 or 9 women will get breast cancer, so we do not want to complicate the screening for breast cancer. So that small subset of patients that have oil emulsion cysts, fat necrosis, irregularities, a fat that took here and did not take on the other side, fat, acute and chronic pain, you will see for yourself not worth the pain and the misery. There is also donor site morbidity, meaning where the fat was harvested from will also, that location where the donor site was also will not be the same. And liposuction, if you ask me, truly is not like a benign procedure in itself. But patients have reported small subset where their fat was harvested from, especially the young patients. It was not the same as after. Now, in my practice, it's all about do no harm. And this is what we're trying to do. We don't want to complicate the screening for breast cancer by altering the screening, mammogram, screening, self-monthly breast exam. We do not want to get these oil emulsion cysts in a small subset of patients, fat necrosis, which inevitably occurs. And not only the surgeon will tell you that you need 1 or 2, but sometimes 3 fat injections in order to kind of build the mound, if you will. Now, another way to answer this question is if you go to a breast surgeon who deals with breast cancer and patients who have had lumpectomies, and now there is a big void, from a common sense answer approach, just take fat and inject it in there and fill it up and call it a day. And good, your own fat sounds good, same aesthetic result. If you ask me, if you ask any breast surgeon, they will say it will only complicate that area because if, God forbid, there is a local recurrence or there is a secondary, and remember that fat that does take in the middle, it might form fat lobules or nodules, and it may make it problematic for eventual screening, self-monthly breast exam, mammogram, ultrasound, or MRI. And majority of the breast surgeons will tell you don't do fat grafting to a lumpectomy area, especially if it's irradiated. And this is, again, what is the goal of life? Not to cause problems, not to create problems, to appropriately screen for what is a real cancer, the most common cancer in women, and to live to 120 without a trip to the doc, right? That's the goal. And this is where you should not, and one cannot. Now, fat grafting to the face, excellent idea. Small, 10 cc's, 15 cc's injected, permanent take. The best supply to the whole body is to the face. And if you're injecting small cc's quantities, you can easily, in a very nice way, really build up the face with fat grafting. But fat grafting to the breast, absolute big no-no in my practice, and bad medicine, if you ask me. You know, I was sitting at a major international conference, and just to the left of me was the chief of plastics at a major hospital of the world, and they have multiple branches all over. I don't want to mention the name out of professionalism. And I asked him, what's your take? Because the topic was on fat grafting. And he said, it's an excellent idea and works well. And I asked him, how about the screening for breast cancer? And he said, well, we can always biopsy, we can always look into, because what we're trying to do is we're enhancing the aesthetics. When I asked him, can you guarantee the patients that they're not going to form fat nodules, oil cysts, acute and chronic pain? And he said, no, not at all. We tell the patients these are the risks. So if you ask a surgeon, board certified, professor of any major university in the US, what are the risks, they will clearly outline for you all the risks that exist. No one can say, oh, my risks are minimal. Just like, for example, the Motiva implants that are being placed, oh, this has less inflammation, they are safe. No surgeon will say they have zero inflammation. Remember, these same Motiva implants are going to cause the same hurt and harm as these older generation. This sixth generation implant is going to cause the same hurt and hurt. Just like the new cigar that came out, it's going to cause the same hurt and harm to the lungs and to every cell of the body. These implants are going to cause the same hurt and harm, especially when they're being placed above the muscle. And so fat grafting for that reason is an absolute big no in my practice. And I absolutely tell my patients to please look into and research and have your surgeons guarantee, which they will never, because this is an inherent part of what is fat grafting to the breast.
When implants are introduced through the armpit, are you able to remove the capsules up to the armpit with your incision in the crease? And the same person says she's 4 months post-op and she has pain and itching on the side of her left breast between the breast and armpit. Is that normal?
So this is, remember, a tract has formed. This is where you have nerves that feed the area, and that is absolutely very much true. So those implants that were placed through the axillary armpit area, they formed the tract because this was the area of dissection. So the many implants that I've removed that were ruptured, that actually tracked into the axillary area. And so I jokingly say with my colleagues in the OR, I do not want to ever take care of a patient who has a ruptured breast implant, because it tracks almost always inevitably all the way into the axillary area and makes the dissection very challenging. And I will say this in a very direct, transparent way. In order to circumvent that problem, I make the incision a centimeter bigger, and now I can use the same incision at the bottom and go all the way up. Remember, I'm not cutting into the breast tissue. I will never cut into the breast tissue. And if it means to make that incision 1 centimeter bigger for me to safely remove this implant capsule that tracks all the way into the axillary area, that is the right, better, and normal standard surgical approach in order to make my life easy. Even if in a situation I am in where there is severe capsular contracture and the patient's implants are here and I have to make my incision half a centimeter bigger, I will absolutely do it because I want to do the surgery safely, definitively, completely. One of my patients came to me and she was operated on by a local surgeon who I happen to know very well, and she had her explant through him. So I called him up and I said, "Why did you make your incision so relatively small compared to the size of that implant?" And he said, "Well, I want my incision small always. I'm a plastic surgeon." I said, "As a plastic explant surgeon, your incisions should be safe, determined, defined, and enough for you to be safely able to dissect not only here but all the way up here." So many surgeons. So let's go back to the other surgeon who I interviewed, and God bless her for sharing and for her being transparent. She herself had stopped augmenting, and she said that she would dissect where the implant capsule was. But then when it came to the upper part and the medial and the lateral part, because that's where the capsule spread is, she would just cauterize it. Remember, that is the real challenge of the surgery, to be able to go from an incision horizontal only and to dissect with the neck bent and the instrument like this in a safe way all the way into the upper part of the chest. And that's why it takes the 4 hours. So another patient went to another surgeon and said, "Well, you can go back to the gym in 2.5 weeks, and the surgery itself too." I said, automatically, the fact that the surgery is in 2.5 hours and you can go back to the gym in 2.5 weeks is the surgery is not done correctly. Period. So going back to your point, the hardest part of the case is the upper part and the medial part from what is a horizontal incision, and that certainly adds to the challenge of the surgery. Now, there was another prominent surgeon in California, and God bless him, I think he did a lot of good for a lot of patients. He would make the cut up and down, cut through the from the nipple down, and he said, "Well, it's better for his neck and back." And I said to myself, "You bet. I would love to do that incision, but I dare not make a cut into the breast tissue." And that is what do no harm means. Do not cut up and down because you're cutting through the breast tissue. So remember, this whole axillary approach done through the armpit is very much not done in today's world and age because there are bacteria. The surgical dissection is not optimal. There is the apocrine and exocrine glands that harbor bacteria within them. And you can, even if you use the calor funnel, this is not a clean area, if you will. Same thing to the nipple areola complex incision. It is not a good incision, if you ask me, at all, because you're cutting right in the middle of the breast at the nipple areola complex. You're cutting the nerves, you're cutting the ducts, you're cutting through the whole breast tissue. To put the implant, if it's below the muscle, or to put the implant above the muscle, and you're cutting through all these vital structures. So right now, for example, if I'm on the ground floor of a 2-floor building and you want to come into the first floor, you're not going to cut all the way from the ceiling and cut to the second floor and then eventually get to the first floor. Just come, make a small cut through the window or at the bottom and come through that way, is because you don't want to hurt the vital structures. So many patients, unfortunately, who have had the nipple areola complex incision, they have had some bacterial overload in the ducts that have seeded the implant, and now they're basically getting problems such as capsular contracture. Remember that those ducts can harbor bacteria. So that is from the nerve perspective, from the aesthetics perspective, from cutting through the whole breast tissue and obscure and affecting the self-monthly breast exam, and potential exposure to bacteria. Despite using the calor funnel, this is, if you ask me, the worst approach, armpit burst approach. And to answer the question, yes, it absolutely needs to be done and can be done and has to be done, no matter what the surgical approach is. And the entire capsular spread needs to be removed, no matter where it extends to. And yes, these are very tricky cases, especially one of my most dreaded cases is where I have to dissect all the way into the axillary area. Or a patient, for example, had an extra capsular rupture, and when they squeeze the implant all the way into the axillary area. And unfortunately, this is a very sensitive area because you not only have the lymph nodes, but you also have the axillary vessels all the way up in the level of the shoulder.
Can you tell us more about the fluffing effect after explant, and what can patients expect depending on different body types?
So this is what happens in majority of the patients. The implants are below the muscle. The breast tissue is above. Anytime you have an implant in the proximity of the breast tissue atrophies, decreases, diminishes. There's limited space. Sometimes it can cause capsular contracture and the breast tissue diminishes. Now, with the implant gone, the breast tissue in itself fluffs out because it has now that space. And intuitively, you can imagine where now it's going to spread out, if you will, especially when it's not being compressed, especially when it is above the muscle. And for some varying reasons, you will see some are going to fluff more, some are going to fluff less. So if a patient is postmenopause, fluff less because estrogen, progesterone is gone, less hormonal influence on the breast tissue. And as you will see, patients that age, they have less breast tissue to begin with. So if a patient is 75, so I saw a mammogram on a 75-year-old patient not too long ago, and it says atrophied, barely notable mammary tissue, breast tissue, primarily fatty tissue seen. And this is what happens. Brain shrinks, skeleton shrinks, skin shrinks with age. So the younger the patient, the higher the chance for fluffing. Less inflammation, less tightness, less capsular contracture. So that 78-year-old patient that I operated on, she was as tight as petrified wood, extremely hard. And if you ask me, very, very bad. Another patient I operated on a couple of weeks ago, same situation, extremely tight. If you touched her chest, breast area, you would see it was hard like a rock. That tissue in the proximity is certainly atrophied more than, let's say, someone who does not have a capsular contracture. So, and sometimes some patients have dense breast tissue. Some patients have less dense breast tissue. Some patients have more fatty tissue that basically covers the fact that there is less glandular tissue. And so the bottom line is, if this is the muscle, the breast tissue above is not touched, whatever the patient has, I tell the patients in a humorous way, well, you have to go talk to your mom and dad, mom primarily, because that's how much you genetically had predisposed to begin with. Because if you had a lot, like one patient said, or no, I said, this is what you had genetically. And this is what her body profile was. And then number two, this is how God made you. So some patients have no breast tissue, and that's why they got the augmentation. When they get an explant, they have no breast tissue to begin with. And so this is where they started off with. This is where they're going to end up with because they did not have much breast tissue genetically. So hopefully that answers your question.
Okay. With the black box warning issued in 2021 for all breast implants that is mandatory according to the FDA for implanting surgeons to disclose along with the patient checklist that many patients are not receiving with no repercussions legally for the surgeon. How would this translate to a black box warning, medication information not being disclosed, either legally, was it malpractice or a medical field type consequences or restrictions? How would that work?
So I'm going to say this to you. This is directly involving the surgeon who's augmenting. So I talked to a patient once, and she told me, my surgeon told me, your implants need to be replaced plus minus 10 years, that they're not lifetime devices, and that there are inherent risks involved with them. And I said, I want to go hug that surgeon because he told you exactly what you needed to listen to. This is a small subset of a small subset, maybe like 3% of my patients that I see, if not less. Now, we sell cars here in Michigan, between Ford, Chrysler, and GM. Now, imagine, if I can use this example, if you came to me wanting a implant, and I read to you whatever I read initially, that they're not lifetime devices. Every 10 years plus minus, you need to replace them. There is association with BIALCL, BISCC, that breast implant illness does exist, right? If you look at the third line, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. This is breast implant illness by definition. We know it exists because the ban occurred, and these are what the patients are saying. Now, the bottom line here is this is the professionalism of the surgeon. If I go tell you, here's a car that's going to catch on fire, that this is going to, transmission is going to blow up, the axle is going to break down, there's electric problems, there is a problem with the door, there is an airbag problem, you're going to run away. This is where, remember, medicine in the United States is a business, be it a cardiology. Ask any nurse, ask any doctor, if you have anyone, and this is no secret. If you ask, medicine is a business in the United States. It's all about hospitals profiting and making money. If you look at the hard reality of the things, it is corruption at its best. And I'm not making this up, and neither am I exaggerating. Any nurse, any biller will tell you this. I was, like a bookworm my whole life till I entered into medicine, and I saw firsthand with my eyes, especially when I started practicing. It was a total surprise. I thought the world was like Mother Teresa. Everyone was, do unto others what you want done unto yourself. And this was, you will see, and I don't want to be negative, but I'm being real. You have to advocate for yourself. There's one patient, 65. Remember, if she were to go to 100 other plastic surgeons, they all will tell her implants are the safest and the best thing. There are many surgeons who say the breast implant illness is a myth, because now they don't have to defend themselves, and here's implants. They don't want to even hear the word breast implant. Now, I will say this to you. My job as a plastic surgeon is, in a very nice professional way, I read out to you what the FDA is saying, what the manufacturers are saying, what the patients are saying. And I am just putting the two and two together in a very nice, defined way. If anything, I'm just educating you about what is breast implant illness. Every human being has a role to be nice, honest, direct, sincere, and to basically not take advantage of another person who's quote unquote, lack of a better word, ignorant. If you ask me, I'm ignorant about cardiology. I'm ignorant about OBGYN. I have no concept of rheumatology. I'm dependent on someone that I'm going to see because I'm putting my faith. Now, you in the real world, my answer to you, and I realized this relatively early on in my career, no one cares. The only one who cares is you, and you have to be your own advocate. And this is that movement by the patients, for the patients, by the women, for the women. And this is where the women are making this educated stand. And, at the end of the day, we know what is the obvious. We know why the ban occurred. We know how they were, quote, the implants were reintroduced to the market. And I leave it up to the system, i.e. the governing agencies, RFK and company, and everyone else to step up and look at what is directly results and data that I just read, and listen to the patients. The problem here is, unfortunately, no one's listening to the patients. Every surgeon has their own mindset, predetermined that this is what's best, and no one's listening to the complaints. And this is where, as you will see, the complaints are only becoming more apparent on the many Facebook, YouTube, Instagram, TikTok posts. And this is the medium that the patients are learning from. We're learning from Danica Kirkpatrick, from the many Hollywood stars that have explanted, the Cosmopolitan magazines that are now publishing about breast implant illness, the National Geographic publishing about what is it to have breast implants. And this is where, a healthy medium like us, we're trying to just educate and say, what, you should have known this to begin with. And if you did not know, this is what you need to know. If you're hurting, there's answers, there's solutions out there. And this is where we're being very professional, and we're saying, educate yourself. So many patients have come to me from very prominent institutions all over the United States. And these same institutions have referred patients to me for a proper explantation, because we're starting to realize that indeed the pathology is real. So where did I get a question from a lot of patients, why did you and when did you realize? I say it's so obvious, you just listen to the patients. Here's the pathology report. It says over here, this is the right breast implant capsule. That's that capsule forms around the implant. And it says here, quote, this is one of my patients, quote, right breast implant capsule, benign fibrous capsule associated with foreign body giant cell reaction, fat necrosis, moderate chronic inflammation. Findings are compatible with silicone mastitis. Mast means breast, itis means inflammation. Negative for active inflammation. This is negative for lymphoma. The residual capsule, so she had the capsule above from her first set. And it says, quote, right breast implant, residual capsule above, excision, benign portions of fat and skeletal muscle. Number C, left breast implant capsule. Again, this is that capsule that forms that must be removed in its entirety. A benign fibrous capsule with associated foreign body giant cell reaction, fat necrosis, moderate chronic inflammation, infiltrate. Findings are compatible with silicone mastitis, nodular fat necrosis. And again, this is anything bad, irregular is removed, is sent to pathology. If you look at G, left breast chest wall mass, this is the mass that was independent of the capsule that I removed. And it says, quote, nodular fat necrosis. So anything bad is removed. And it says over here, the next, another patient, it says, quote, right breast implant capsule, refractile foreign material associated with multinucleate giant cell reaction, compatible with reaction to foreign material. So these are the foreign materials. This is the gel bleed that's within the capsule. And remember, this whole surgery is about the capsule. So many surgeons have approached me and said, why are you removing the capsule? Why are you determined? That's where those 3 patients with CD30 positive did not need removal of their capsule because I had done it correctly. Those patients with fungus and candida did not have to have a second surgery to remove that residual fungus. Those patients with breast cancer, because they had a history of breast cancer, I had removed that capsular tissue with inflamed tissue that had breast tissue next to it, which should not have had been present because the previous surgeon should have done the true mastectomy, which was not done. And I removed breast cancer in 3 patients in the last few years. Those patients that had fluid around, none of that fluid leaked into the chest. That one patient had severe heavy bacterial load, all contained pus removed in en bloc fashion, did not need to have a washout or drain or an admission to the hospital for chronic antibiotics for 7, 10, 14 days through a PICC line because the surgery was done correctly the first time around. Those many patients that had that bloody discharge, and please go to drkhangallery.com, did not have to remove that capsule. You saw the gel bleed where it's leaching of the silicone into the capsule. And we know it's embedded, the refractile material within the capsule. That patient did not have lingering 30, 50% of her symptoms lingering on because the entire capsule was removed. And if you look at the same FDA documentation, you will see at the top, and this is top of systemic symptoms, page 13 at the top. I understand that some patients have received breast implants have reported a variety of systemic symptoms. This is very ironic, interesting, funny, comical, the way they're writing this sentence. If you look, they're saying, I understand that some patients who have received breast implants have reported a variety of systemic symptoms. This is just like saying, we have heard from some patients who have had high consumption of sugars that they have reported a variety of systemic symptoms such as, no, just call it diabetes, right? In this case, quote, I understand that some patients who have received breast implants have reported a variety of systemic symptoms such as joint pain, fatigue, rash, memory loss, and brain fog that some patients have called breast implant illness. They're afraid and timid to even call it. What a shame. They should just say it exists. It's breast implant illness. While the causes of these symptoms are unclear, some patients have reported relief of these symptoms with the removal of their implants and surrounding scar tissue capsule. So they're telling you remove the capsule. However, not all patients may experience improvement in their symptoms because it has spread to the chest wall, it has spread to the lymph nodes, it's spread to the liver and elsewhere. And no matter if you remove it, the badness is already spread because it's a ruptured implant or if it's leached out into the periphery. So they're telling you that scar niche tissue capsule needs to be removed. If the patient has fungus, breast cancer, CD30 positive, a ruptured implant, you want to definitely do the end block then. Why would you want the silicone to spill into the chest, right? So those are all reasons for removing the whole capsule. Case closed. So if I'm the president of the US and I am a female and if I'm getting the surgery, I want it done quote this way because we don't want to go back for a second surgery. And this is where every patient that I operate on, it's done with absolute sincerity, integrity. There is no rush in the surgery. I had a patient wait 2.5 hours. She literally wanted to hug me and she was in tears because she said that you're going to do the same for me as well. And that is, you never know. There are patients that have gone in. She said, I have saline implants, and it turned out it was a ruptured silicone implants. And you can only imagine how angry the patient was that she always thought she had saline implants because that's what she had paid for, and vice versa. And so the surgeon has to always assume the worst. Going back to if you put the two and two together, there is a mountain of evidence that speaks for what it means to have implants, what are the implications, and what is the long-term ill effect of having implants, and what the patients need and must know, because this is should not be kept a secret. And this is two words: informed consent. Not only when placing, informed consent, also when removal, and it should say on the consent form exactly what and how the high definition pictures. Consent must say total capsulectomy and block, high definition pictures, capsule center pathology, incision, and the surgeon's mindset. That is your when you choose your surgeon, you're choosing your surgeon's mindset. Most of, if not all of my patients that come to me, they know me personally because not only they, but their husbands, significant others fall asleep listening to my videos because they know what they're signing up for. Any other questions, John?
Um, I am 54 years old. Do I need to be fit to have the surgery? And how long will I have to stay in Michigan after surgery? What type of lab work do I need? I'm pre-diabetic with high cholesterol.
Got it. Okay. Now, regardless of the surgery, you should be fit. That's 101, including myself. So we have to watch what you eat. You are what you eat, right? And your diet and exercise goes a long way. Remember, half of what we eat in the U.S. is processed food, pure utter garbage. And so you have to be smart. You have to get the apps, organic, non-processed whole food. It's expensive. Eat less. You have to eat smart, and you have to eat the right stuff, regardless of the surgery. Number two, you have to be very careful what supplements you're taking. Supplements is a big business, multi-billion-dollar industry in the U.S., which is, sorry to be blunt, also pure utter garbage if you ask me, because the doctors themselves will tell you we do not know what's in the product, what is in the product 6 months from now that they're selling again, and they will have this nice fine disclaimer at the bottom, not responsible, in this is totally on you. Number three, when you need to go to your doc to get a medical clearance, that means, and you come to me, that you're not diabetic. So one patient came to me, her A1C was 10, another one 8.5. I said no surgery till you bring it below 7 for your own good, because we do not want wound complications. Want to make sure your iron level is good, want to make sure your thyroid is good. One patient in the middle of California, she said, I don't believe in doctors, and I've never seen one in the last 20 years. She's going to her doctor. She's going to get a full set of labs, full set of workup, full exam for her own good, regardless of the surgery, to make sure she does not have Hashimoto's, low iron. She does not have, God forbid, breast cancer. She gets appropriately screened, and she is presented to me on that medical clearance form that says patient's in excellent shape and health for the surgery. And the patient herself mentally is prepared for the surgery. This is my best patient, so they know what they're signing up for. Now, your doctor is going to determine what is the right lab test for you. So if they do an EKG, it looks a little bit, quote, suspicious. Well, guess what? You are getting an echo, Holter, or a stress test as determined by your doc or your cardiologist if they do determine. And remember, this is your doctor's responsibility. So millions of surgeries are done in the U.S. where they do ACL or rotator cuff or hernias elective surgery. These patients go to their primary care doctors, and in likewise fashion, my explant patients go to their doctor, and they themselves, their primary care doctors, determine what it is that needs to be done in order to present to me that they're safe and sound and healthy. Now, I review that each and every single medical clearance, plus my anesthesiologist and my CRNA independently of me, and we filter all of our patients, majority of which travel from out of town. 80% or so my patients travel from out of town. So I've never seen them. So when they do come to me, I have the peace of mind that I felt myself have filtered them, and I myself have basically, the primary care doctor has basically vetted them. Now, one patient came to me, she did not tell me. She and her husband were on the phone call together, and I encouraged that. Two minds are better than one. And she did not disclose to me she had seizures. She came to me and she mentioned to me for the first time she had a seizure 2 weeks ago. Automatically, case canceled. She came from to me from out of town, I believe Tennessee. Case canceled. I do not care. I need a full neurological workup because remember, this is all for you. Anyone else would have continued on with the case. This same patient said, I will sign on the paperwork. I take full responsibility. Send me to the hospital across the street. I said, no, I want to, no turbulence on the OR table. So going back to the point, your surgeon, your doctor is going to determine that you're healthy, safe, regardless of the surgery, and certainly for the surgery that your heart is good, your labs are good, your endocrine system, everything else is good, and they're optimized and ready for surgery. And when you do come to me, I have the peace of mind along with my anesthesiologist or the CRNA that you're ready and cleared for surgery. Now, the second thing is you would come and see me on a Monday in clinic. Tuesday, the surgery would occur. You would then recover Tuesday, Wednesday. Thursday, you see me in clinic and you head back home, essentially a 3-night stay in Michigan. Now, if you are my patient from Seattle, no matter how early you get up and you take the flight with the 3-hour difference, the earliest you're going to make it is 4 p.m. to the airport here. So you would have to come in the day before, and that certainly adds to the length of time. But my Seattle patients have made it to Los Angeles, and so they certainly find it convenient time-wise, distance travel-wise, or they have a friend or a family member. So you would essentially, this is how it has turned out. In California, for example, you would see me in clinic on a Thursday. Remember, you never want to see your surgeon on the day off. I see some patients who have gone to other surgeons who saw their surgeon for the first time an hour before surgery. That's big no-no as far as informed consent. So you would see me on Thursday in clinic. Friday, the surgery would occur, or Saturday, and then I would see you Sunday, and then you would head back home. And if I did your surgery on a Sunday, I would see you on a Monday, essentially 24 hours later, and you would have had the peace of mind that everything would go back. Just yesterday, I talked to a patient in California who wants her implants removed, and I determined that I was not going to choose her as a patient. Just like my patients have a choice to choose me, I choose my patients, and there are absolutely a lot of patients that I have turned away because I did not want to operate on them. Number one, they were going to be non-compliant. Number two, they were complex. They had a radiation. They did not meet the criteria because remember, I want not excellent results. I want stellar results. I want anyone who's going to commit to me. 50% is the surgery. The other 50% is the recovery. So if you do the best knee replacement and 2 days or 2 weeks later, your patient starts walking, no matter how good the knee replacement was, it's going to go down the drain. Same thing with the explant. You want total commitment to me. You will talk directly to me, not my PA, because I don't have one. You'll not talk to my nurse. You'll not talk to my medical assistant or my office manager or my front desk person. You're going to only talk to me. Every patient has my cell phone number, and you will 100% get that direct feedback because it's all about perfection. It's all about that absolute sincerity. I only do so many of these a year, and I make sure that everyone that I do, it's like I'm taking care of the president. And the other thing I want to mention here is you have my cell phones. These are real patients, by the way, just so that you know. 2 days ago, I got a text from a patient if I could get a pedicure. Please do not at the end of the day, it's not uncommon for me to have 35, 75 texts. Now, I'm very good about, quote, telling them, don't waste my time, and again, we want connectivity, or if there are questions that can wait till we talk, absolutely, please wait. Because remember, my job is to help you recover literally on a 24/7 basis if I need to, and I'm right there with you, making sure that you get the most and the max out of me, which no one does, and I know that because my patients tell me, and I talk to my colleagues as well. And I want to make sure that you're going to have the best recovery. So one patient got a rash, I want to know about it. One patient got diarrhea, I told her to stop the antibiotics, and I want to know about it. Another patient had nausea, vomiting right after, and I want to know about it because I want to make sure that you're going to have a peaceful, nice post-op course. And so we work together, making sure that you're going to be taken care of 100%. So if you're coming to Michigan or California, you're looking at essentially a 3-night stay. Thursday night, Friday, Saturday, and then you head back home if you're in California. In Michigan, you come Monday for the pre-op visit. Tuesday, the surgery occurs. You recover Tuesday, Wednesday, Thursday. You see me in clinic, and you head back home. And remember, this is where my patients feel very comfortable, and I feel very comfortable discharging them. And this is from one patient to the next, where they have not had any issues. And I follow them very closely, and I am the only one who knows what's going on. No other person will ever come to even close to knowing what I did in the operating room because they don't understand the surgery, and I want to know everything about it. I'm very much hands-on, and so this is done very safely. Now, there are some people who will try to promote a business by they want you to stay in their Airbnb for 7 days because they want to max out. This is absolutely wrong. 3 days is more than sufficient. Now, if a patient came to me from Switzerland, and she, just because of her financial situation and she felt comfortable, she brought her family, and she had a 10-day stay here because when she wanted to head back, she just wanted a peace of mind and she wanted to enjoy Michigan. Absolutely, you can do that. Another patient came for a couple of weeks to have fun with her daughter up north in Traverse City, which is perfectly fine to travel to as long as you're in the TRX arm mode and limited arm movement. Certainly, I require you to walk the next day with full precautions. Remember, the anesthetics have worn out, and absolutely, if you're on pain meds, you need to be full precautions regardless. But this is where your friend or someone who's there with you, your family member for the first 24 hours, is there to help make you be out of bed to cheer on the day of surgery, and the following day upping and walking about gently 10-15 minutes, then taking a break, because that is certainly only good for the recovery, for the breathing, DVT prophylaxis, and overall a better, smoother recovery. Any other questions? All right. So there's a lot of good information we shared here. Thank you very much for those very insightful questions. The other thing I want to mention here is if you go to my web page, you will see questions to ask your plastic surgeon. And you will see, there's only 15, 20 questions you can ask your plastic surgeon. Do you use drains? So let me answer that very fast and in a defined way. If all the badness is removed and the capsule is not cauterized and no silicone spills into the chest, the drain is not required. The last time I even used a drain was well over 7 years ago. And look how many of my patients have gone back home to their respective states overseas, and they did not need drains. They did not say, hey, the doc was great, but I needed drains. Conversely, the burden goes on to those surgeons who use drains, because if you're doing the surgery correctly, drains are not required. Number 2, the pseudo lift we talked about. Number 3, are you board certified? You bet I am board certified. I have privileges at the hospital. Just having privileges at the hospital, you get verified, checked, and balanced by the system, by the state. Remember, the hospital will never board certify, will never qualify the ENT surgeon down the street or the general surgeon down the street or the ER doc who is 35 minutes away from here to operate as a plastic surgeon. Because you're a plastic surgeon at the hospital, that automatically authenticates you to be legit and real and to not have a bad professional background. Unfortunately, many general surgeons are now trying to jump in and try to do explants because they're in the middle of God knows Tennessee, and they are the only surgeon around, and this patient is unfortunately, quote, lack of a better word, naive to going to him because he says he can offer that service. So you will see those 15 questions are key. Where do you do the surgery? It's at a board certified Quad A, the gold standard of operating rooms outside of the main hospital. I've operated on a lot of nurses, medical staff, physical therapists, occupational therapists, and they all prefer a setting like this where you're not at the hospital. I operate in California. I operate here at the surgery center, Landmark Surgery Center. I operate at the hospital as well. The last patient I did was a patient with a pacemaker at the hospital, and certainly all pacemaker, bad COPD, bad heart patients, patients with stent in the carotids need to all go to the hospital. The hospital, if you ask me, is not the ideal setting because whenever I do go, I do not know who's my anesthesiologist or my CRNA. One day I went there, I had a resident anesthesiologist, which is very safe and done as a standard of care across the country as long as they have good supervision. I do not know who my circulating nurse is. I do not know who my surgical tech is, but I take my first assist, who is my right hand, who ensures everything is done exactly how I do it here in Los Angeles and here in Michigan. And the bottom line here is it's all about quality control. And everything starts off with me and ends with me in my practice. And I'm very much hands-on for those many patients who will attest to the fact. So do your homework, do your research, join the private breast implant illness support group page, join the public group page, join the YouTube channel, subscribe. 5 minutes here, 10 minutes there. Initially, you might be overwhelmed, but a month later, 2 months later, you will see that you will be an expert as to how I do it, not how everyone else does it. And this is where you yourself have to ask the surgical approach. This one patient was very smart in the middle of Colorado on a mountain where you have to not only drive your 4x4, but after that you have to take a snowmobile to the top of the mountain. That's where she learned about me and she found out how I do the surgeries. She pretty much had my videos memorized and she said, this is the only surgeon I'm going to choose. And lo and behold, she did come to me and she got her surgery just like she had anticipated. She got the high definition pictures and videos and she went back knowing exactly what was done. And this is the transparency every plastic surgeon should offer their patient. If you get your gallbladder out, who cares? When it comes to explant, you need to know exactly how it was done, what happened to the capsule, what were the findings. You have to be very meticulous. You have to be your own advocate, and you have to ask the questions. You have to do your homework. You know, let me use this example again. We sell cars here in Michigan. So we'll use that as an example again. A person wants to buy a car. They go in literally within half an hour. This 22-year-old decides to buy this car, and just 2 weeks ago, she had not even thought that she was going to buy that car. You don't want to be this patient. You want to have thought about that car for 6 months. You want to thought about all the problems, all the post-op, all the findings. What is it that the surgeon is going to do? You need to indulge, absorb, and involve and engross yourself with the surgeon's technique, the surgeon's mentality, the surgeon's discipline, the surgeon's previous patients, having talked to them. Do not naively listen to another Facebook group owner who got financially persuaded to promote the surgeon because they got a nice donation this month and they advocate and they're getting paid. They are on their paycheck. This person is an influencer. The influencer is not operating on you. And if you don't meet that criteria, I promise you, you will not be getting your right surgery because this surgery is all about transparency and disclosure. So do your homework. And in my practice, I tell the patients, you're the boss. You decide what you want, and you come to me willingly, happily, in a smiling face, and with that utmost desire that you're going to get healthy because these implants are hurting and harming you. And this is where I and you as a team work together from the beginning to the very end till you're discharged so that you got the max out of not only me, but my entire team, my front desk, who work very hard to make your every experience better. Now, with that, We'll go ahead and do this again soon. And please listen to the podcast. And absolutely, last but not least, Dr. Khan Gallery, Dr. DRKHAN gallery.com. And please, we will certainly make announcements for the live that I'm going to go through, so you can certainly join. And please spread awareness and let many others know about what breast implant illness is. If you don't have it, excellent. Not everyone will get breast implant illness. You have to be in the anticipation phase always, because remember, they're not lifetime devices, so you know if a problem does arise that you have help available. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan, and also Greater Los Angeles, California. Thank you very much.